All right. So, welcome back. This is part two of the midterm review, and we're going to start where we left off. So, this is just a review of the A1Cs. So this is kind of a comparison chart to show where the A1Cs compare to an average glucose level. So you can see if somebody's A1C comes back as 4, it equates to 65. If it comes back as, say, a 7, it comes back as 107, it's about as 170. If it's an A1C of 10, it's about 275. So you can see that's about an average. All right, DKA. So, DKA, diabetic ketoacidosis. Symptoms you can see polydipsia, polyuria, weakness, fatigue, nausea, vomiting, pain, disorientation, confusions. They're going to look sick, dry mucous membranes because they're going to be dehydrated, decreased reflexes, catatonic breath, tachycardia, hypotensive, tachypnea, hypothermia. Complications with this, cerebral edema, hypokalemia, ARDS, pneumonia, MI, acute kidney injury. Lots of people recover from it. However, again, you can have a lot of issues. All right, insulin. So, rapid acting, you can see here. Onset 10 to 30 minutes, peak 30 minutes to 3 hours, duration 3 to 5 hours. Your short acting, onset 10 to 30 minutes, peak 2 to 5 hours, duration up to 12 hours. Intermediate, that's your NPG. Uh, onset 1.5 to 4 hours, your peak 4 to 12 hours, your duration up to 24 hours, your long acting, like your Lantus and things, uh, about 0.8 to 4 hours, minimal peak, and it lasts up to 24 hours. Exercise in diabetes. Exercise is important, it helps to maintain and lower your A1C. However, can lead to hypoglycemia, so each person is different. They may need a snack before, during, or after exercise. So patients should be aware of that. So one thing to know, and some patients need to monitor their ketones. Hypoglycemia, it is more common in women and elderly. It's essentially low blood sugar levels. A lot of different causes, endocrine disorders, bariatric disorders, insulinomas, neoplasms, liver disease, pregnancy, medications, alcohol. Most important thing, small frequent meals, eating lots of protein. Lots of complications from diabetes, retinopathy, cardiovascular disease, heart disease, kidney disease, neuropathies, peripheral vascular disease, ulcerations, amputations. All right, metabolic syndrome. That's syndrome X, insulin resistance. Lots of risk factors with this. Same things we've been talking about. Cardiovascular disease, diabetes, fatty liver, cancer. You can see the symptoms here. And diagnosis, they have to have 3 of 5. The elevated fasting glucose, elevated blood pressure, triglycerides, low HDL, and elevated waist circumference. Treatment, lifestyle, weight loss, statins, niacin, fibrates, omega-3s, metformin, get their BP at goal. All right, endocrine. Hypothyroidism versus hyperthyroidism. So, your hypothyroidism, high TSH, low or normal T4, and you're going to treat them with thyroid replacement. Hyper, they're going to have the low TSH, high T4, also Graves' disorder, may be treated with beta blockers, radioactive iodine, and you can see the differences here in symptoms. Essentially opposite, intolerance to cold, intolerance to heat. This one constipated, this one might have diarrhea. All right, pulmonary exam findings. So, same thing, inspection, palpation, auscultation, percussion. We're going to look first. Are they using accessory muscles? What's the shape, color, respiratory rate, breathing pattern? We're going to palpate. Is there crepitus? What's the symmetry like? What's the temperature like? We're going to listen. Are there crackles, rails, wheezes, stridor? Is there a pleural rub? Are there normal sounds? Percussion. You're going to hear dull sounds over high density areas like a pneumonia or atelectasis. You're going to hear low pitched hollow sounds in normal tissue. Common respiratory disorders, upper respiratory infections, common cold, flu, COVID, your pneumonias, bronchitis, croup, bronchiolitis, RSV, pulmonary embolus. All right, your asthma. So, differential diagnoses of asthma, COPD, pneumonia, GERD, chronic rhinosinusitis, CHF, vocal cord dysfunction, foreign body aspiration. So, when you're thinking about diagnosing somebody with asthma, you got to think, could it be one of these other disorders? Triggers of asthma. Could be air pollution, could be cigarette smoking, occupational exposure. Where do these people work? Are they exposed to any of these things? Indoor allergens. Where do they live that they could be exposed to this? Outdoor allergens. Viral infections. Does it only come on when they're sick? All right, and so we have different classifications by age. This is a classifications for children 0 to 4. We also have classifications for ages 5 to 11. I'm going to kind of talk about the 12 plus. So you can see here, we have intermittent, mild, moderate, and severe. So you can see, based on symptoms, nighttime awakenings, how often they're using their rescue inhaler, their interference with normal activity, and their lung function. And that's how you determine if it's intermittent, mild, moderate, or severe, and persistent. And if they're at risk, and that's recommended step for initiating treatment, you can see, are they at 1, 2, 3, or 4? So I include this here, types of respiratory medications. There are so many different inhalers, and I feel like every year they just come out with more to just confuse everybody more, and they all have different names. And I feel like it's very confusing for everybody. So they do have these nice charts, and while this is a little bit difficult to see, especially on the video, if you can get one of these when you work in your office, I think that this is going to be very helpful for you because it's easier to look at. So up top here, you've got short-acting beta agonists, so SABA, okay? Vanillin, Xopenex, Proventil, ProAir Respiclick, okay, that's what's up here. You've got long-acting beta agonist bronchodilators, Ceravent. Unfortunately, I can't read that one. Now we've got inhaled corticosteroids, okay? Asthmanex, Flovent, Pulmicort, Qvar. Now we've got, come down here, and we've got all of our combination medications. We've got our Advairs, Brios, Bevespi, Trilogy. Now we've got our anticholinergics and other combination medications, and PDE4 inhibitor down here, bronchial thermoplasty, biologics. So that will be very helpful in the future for you. Stepwise treatment you can see here to help you. And if you take this, use your chart, it will help you in the future. All right, chronic cough, over 2 months. What could it be? It could be allergies, could be rhinitis, postnasal drip, could be from an ACE inhibitor, could be from GERD, could be from asthma, COPD, CHF, pertussis, bronchitis. Smoking cessation, you want to assess this at every single visit, even if they don't like it. Okay? It's part of our job. Okay? You want to refer them to smoking cessation programs. Okay? But they do need to be ready. But again, you do need to assess it. Nicotine replacement, hypnosis, medication, Zyban. Again, Chantix was removed from the market. Does cause cancer. Okay? Small cell, lung cancer, and bladder cancer, heart disease, stroke, lung disease, diabetes, COPD. All right, community-acquired pneumonia. Most common causes, strep pneumonia, Okay, Hib, mycoplasma. Your curb 65, you want to make sure to know that. That's your score for your pneumonia severity. Okay, your estimates your 30-day mortality rate. And it recommends, do you need outpatient, inpatient, or ICU treatment? Okay, here's your empirical treatment. Okay, if they have no comorbidities, you want to choose one agent. Amoxicillin, first line, doxycycline. Okay, zithromax, clarithromycin. If they have comorbidities, you can see here. That's what you do. Types of bacterial infections and colored sputum. So if they got strep, it's usually rust-colored, Pseudomonas, Hib, pneumococcal is green, Klebsiella, red currant jelly, anaerobic, foul-smelling, bad tasting. PFTs, you can see in their asthma care plan, this is what you do. Green zone, yellow zone, red zone. This is how you develop your asthma care plans. Okay, this is the asthma care plans. That's for your peak flow testing. Okay, your spirometry. That's what you do in the office. You should do this once a year on all of your respiratory patients. Okay, it helps to measure their lung volume, see where they're at, measure their FEV1. That's the amount of air you can force from your lungs in 1 second. All right. COPD versus chronic bronchitis. Okay. Follow the GOLD guidelines. Okay. COPD is irreversible, where asthma is considered reversible. You can see here, this is the difference, chronic bronchitis versus emphysema. And here, these slides we talked about in the previous presentation about this is how we assess, treat, and monitor COPD based upon the GOLD guidelines. Okay, how we determine whether someone's having the exacerbation, what we do, and how we treat them. Do they have hospitalizations? What medications do we put them on? You know, are they just having increasing shortness of breath? Are they having more exacerbations? Chest x-ray findings. Pleural effusion, likely from CHF, cancer, pneumonia, PE. Blunting of the costophrenic angle, probably from fluid or consolidation. Hyperinflation, usually asthma or COPD. Flattening of the diaphragm, COPD. Infiltrates, pneumonia or abscess. Chronic lung diseases, cystic fibrosis, again, genetic disorder, usually tested with the newborn screening, sweat test, genetic analysis. Lung cancer, you want to do your low dose CT scan, counsel for their risk factors. Your sleep apnea, you got all your testing that you can do, your tests in the office with your scales, your overnight sleep studies, and your multiple sleep latency tests. Again, linked to diabetes, stroke, MI, obesity, shortened lifespan, hypertension. Tuberculosis. The major concern is drug-resistant and multi-drug resistant TB. Testing your skin test, and you can see here when you're testing, when you're determining whether it's positive or not, is going to determine based on the patient's risk factors. Are they HIV positive? Did they have recent contact with a positive patient? Are they an organ transplant patient? Are they an IV drug user? All of that is going to be important. Do they have no risk factors? You can also do the quantiferon chest x-ray. So you can see that. These people need long-term therapy and monitoring. All right, so that's it. Good luck on the midterm. Please let me know if you have any questions.